So this is the outline for today's talk. I'm sorry, the part of the screen is getting obscured. Now I hope you could see the entire screen. So this is the layout for the talk today. Before we speak about Wilson's disease, I would like to recap the history about Wilson's disease. The disease was named for Dr. Samuel Wilson, who was an American-born British neurologist, where he discovered the association between lenticular degeneration in the brain as well as cirrhosis of the liver while he was pursuing his doctoral degree. Since then, there had been so many developments with the Wilson's disease evolution, its diagnostics as well as its therapy. So I would like to give a brief overview before we discuss the facts in detail. Wilson's disease is a rare disorder of copper metabolism and it causes copper toxicosis or else copper overload. The worldwide prevalence is estimated to be 1 in 30,000. The disease is genetically inherited in autosomal recessive manner and the mutations lie on ATP7B gene, which is located in long arm of chromosome 13. Looking at the clinical phenotype, hepatic phenotype predominates in children, while neurological features become more and more apparent towards adolescence and adulthood. How are we going to make the diagnosis of Wilson's disease, which we will discuss in detail? However, briefly, it is aided by genetic testing as well as Wilson's diagnostic score. In treatment-wise, copper chelators are the mainstay of medical therapy, and the other alternative method is liver transplant, which should be selected carefully. And the transplant may be required to rescue children who would present with acute severe scenarios or sometimes who have got established cirrhosis of the liver. Reported short-term as well as long-term outcomes are quite satisfactory in Wilson's disease, provided the appropriate management strategies have been chosen in a timely manner. Before moving to the clinical facts, I would like to briefly tell about the sequence of events in pathophysiology. And this will be briefly mentioned because it's not the main focus of the talk today. However, it will be important to have a background idea about the pathophysiology. In Wilson's disease, what you get is the mutations of ATP7B gene. ATP7B gene is responsible to code the protein which is acting on copper transporting mechanisms, which is a P-type ATPase. And that has some effects on ceruloplasmin production. Ceruloplasmin is a main modality or a main protein which is involved in copper transport from liver, from tissues, outside the body, and finally to the excretion. Defective mutations leading to defective transportation of the copper would result in increased accumulation of free copper within the cells. Free copper is not quite good to the cells. It will cause free radical mediated cell damage. And if it is happening in the liver, it would cause cell damage and the liver would try and attempt to repair. However, this attempted repair would result in fibrosis, finally causing cirrhosis. And in contrast, if it is happening in the brain, it might cause astrocyte damage, demyelination, and its mainly occurrence in basal ganglia and thalamus. So the basic mechanism is copper overload due to defective copper transportation. Let's move to the more interesting facts about clinical presentation. What kind of a disease is this? It's quite heterogeneous, where you can have a lot of presenting patterns ranging from mild varieties to very severe varieties. And diverse presenting patterns are inherently known in Wilson's disease. The average age at presentation is usually around 10 to 13 years, where the range could be between 5 to 35 years. And this age range is for symptomatic individuals. You can detect asymptomatic individuals through family screening even on day 1, day 2. Importantly, 1/3 of them would not have symptoms at the time of the presentation. They might be detected through family screening and it may be incidentally found when the child presents to the pediatrician or to the pediatric casualty or to the general practitioner with some sort of intercurrent illness, and if the physician has requested liver function test, sometimes it might incidentally reveal that liver functions are abnormal. Then it's not really related to the intercurrent illness, however, maybe the manifestations of Wilson's disease. And sometimes bright appearance of the liver on ultrasound scan, which is performed for some other reason, may be the first step where you would investigate further for Wilson's disease. The reason for the bright appearance on ultrasound scan is the initial stages of Wilson's disease could cause steatosis, which might give you a bright appearance in the liver. Classically, the symptomatic children present with hepatic disease, which could be varying in severity. However, neurological features do occur. They are unfortunately often overlooked in children due to multiple reasons. In young children, it may be difficult to elicit neurological features, and they may be very subtle, and sometimes they present with severe acute hepatic presentations where you might not think towards neurological involvement. By definition, Wilson's disease could affect any organ in the body. So other systemic manifestations like hemolysis, anemia, joint symptoms may be the first presentation of Wilson's disease. Let's look at some of the aspects of hepatic phenotype. It's usually the first presentation up to 60% of individuals, and you could see various manifestations in these pictures. The liver features could range from incidentally detected raised transaminases to acute and chronic liver failure or established cirrhosis with portal hypertension. Sometimes it might just present with isolated hepatomegaly, acute hepatitis, or maybe acute liver failure. It's quite important to understand the difference between acute liver failure and acute and chronic liver failure. One might think it's very straightforward. Yes, it is. However, when the first presentation is quite acute, we try and label them as acute liver failure. Most of the Wilsonian children present with acute and chronic background. Acute and chronic liver failure, where the first presentation is in a kind of acute scenario. The features which would support your chronicity would be the presence of portal hypertension, presence of persistently low synthetic functions, and the liver biochemistry. And the gold standard would be the liver biopsy and histology, which would show the established cirrhosis. European Society of Pediatric Gastroenterology, Hepatology and Nutrition recommends to suspect Wilson's disease in any child who's more than 1 year with undiagnosed liver disease. So high index of suspicion should be needed to diagnose Wilson's disease if you have undiagnosed liver disease. And they have brought down the age to 1 year because to increase the sensitivity, as it could occur even at the age of 1 year. I thought I would share some of my experience which I had recently to elaborate and give some practical importance to what I talk about. So these are the data from Birmingham Children's Hospital, where we evaluated 67 children and adolescents who had Wilson's disease over a period of 30 years, 2018 backwards. I was instrumental in carrying out this project as the primary investigator, and we presented this in British Society of Pediatric Gastroenterology, Hepatology and Nutrition in this year and awaiting the publication. So when we looked at these 67 children, what we found was 10 of them were siblings who were diagnosed with family screening. And we had 57 index cases, and you could appreciate the majority of them had hepatic presentations. And of them, the majority were acute and chronic liver failure. And there were presentations like neurological and hemolysis or hematological as the first presentation to the hospital. Importantly, as I mentioned earlier, 1/3 of the cohort was asymptomatic at the time of the presentation, where they were found to have incidental diagnosis of Wilson's disease with abnormal liver function tests. Let's look at the neurological phenotype. We know brain is the second most common organ which is affected with Wilson's disease. And it's well recognized to have neurological or neuropsychiatric features in adults. The neurological features could be subtle in childhood, so sometimes it is not very much detected or looked for. One of the important things to understand would be you could still have abnormal neurology with the absence of symptomatic liver disease. They do not necessarily have liver abnormality to be symptomatic for them to have abnormal neurology. What would be the neurological features you have to look when you encounter a child suspected with Wilson's disease? It may be quite obvious, like movement disorders, tremors, dystonia, dysarthria, so on, and maybe motor developmental delay. Changes in the speech and abnormalities in the speech are quite characteristic, and you have to have high degree of suspicion to inquire them. On the other hand, it may just be mood disorders, depression, mania, anxiety. Sometimes it might be mislabeled as schizophrenia. Subtle cognitive defects may also be present. It's very important to inquire about recent deterioration of school performance when you are evaluating a child. It could be quite subjective. However, asking about very recent deterioration where the school performance had been adequate previously becomes important. This may be due to multiple reasons. Child might be having tremors which might impair the handwriting, and child might be having cognitive defects which might impair the understanding. So assessment by an expert neurologist is quite helpful. The most important messages I would like to highlight are more than 5% of children with hepatic presentations have neurological features at initial presentation if you have inquired properly. And more than children with Wilson's disease develop neurological features during their childhood at some point while being on follow-up. Again, I would like to share some clinical experience pertaining to neurological involvement in Wilson's disease. On your left-hand side, you could appreciate the King's College experience regarding neurological features and Wilson's disease. They conducted a retrospective study looking at 57 children and adolescents with Wilson's disease over a 37-year period. And these were the neurological features they found. In contrast, we looked at our cohort while I was in Birmingham, looking at 67 children, and these were the neurological features we found. We have not included encephalopathy here because it could be related to hepatic encephalopathy, and it's doubtful whether we could really label it as Wilson's related neurological disorder, where you could have hepatic encephalopathy in other conditions. And it's quite difficult to differentiate encephalopathy due to Wilson's disease alone as a neurological manifestation or related to hepatic encephalopathy. And we have excluded lethargy. We have not assessed that because it's quite subjective as well. One important fact which I would like to highlight here is both these studies were retrospective. And if you perform a study prospectively, you might understand this may be the tip of the iceberg, where you might detect more and more neurological features in children, because all these were documentary facts where we have not assessed children prospectively. The other question would be, is there any correlation between severity of the hepatic phenotype and the neurological presentation? Do you need to have severe hepatic disease or cirrhosis for you to have neurological disease? The answer is no. If you look at these three children where we have analyzed in depth, these three children presented primarily to the neurologist initially with neurological phenotype. Then they were diagnosed to have Wilson's disease and subsequently referred. You could appreciate their ages, and if you relate the changes on liver biopsy, 2 of the 3 had only minor changes in the liver biopsy, and only 1 had chronic liver disease with portal hypertension. However, all 3 had significant neurological abnormalities for them to present to the neurologist. It's important to understand you don't need to have severe hepatic disease for you to have neurological disease. That would be one of the take-home messages. And expected clinical phenotype, whether the liver is going to affect mostly, whether the brain is going to be affected mostly, or whether the other systemic manifestations would be the predominant features, would depend on the underlying genetic mutations. However, it's quite hard to propose a genotype-phenotype correlation because more than 700 mutations have been identified. So day by day, people are trying, but it's becoming harder and harder to identify genotype-phenotype correlation. However, there is some genotype-phenotype correlation which is indicated by this data. So far, we have looked at hepatic manifestations as well as neurological features. We'll briefly see what are the other systemic manifestations which could be there as part of Wilson's disease. We all know K-Frinks are classical in Wilson's disease, and it has got a quite high sensitivity for the diagnosis. And you could appreciate in future slides, it is part of the Wilson's diagnostic score as well. Other eye manifestations could be sunflower cataract, saccadic eye movements. Certain children might present with hematological manifestations like non-immune hemolytic anemia. The characteristic feature is you will get hemolysis, however, the direct antibody test or Coombs test will be negative. And this hemolysis could be acute, could be low-grade chronic hemolysis, or sometimes it may be intermittent hemolysis. What is the reason for these children or adolescents to get hemolysis? What's the mechanism? The theory postulated is free copper is toxic to the red cells, and if it is in high concentrations, it might cause direct damage to the red cells, causing hemolysis. Looking at the other organs, kidneys, you can have Fanconi syndrome. Arthropathy and arthritis may be a manifestation of Wilson's disease, and sometimes the other organ involvement like pancreatitis, cardiomyopathy, endocrinopathies have been reported. This is to illustrate the K-Frinks as well as sunflower cataract. Let's move to have some discussion or talk regarding investigations and how to interpret them in the context of Wilson's disease. Before moving to specific investigations, I would like to elaborate on basic investigations we would start with any child who come across in clinical practice. Firstly, we would do some hematological investigations. And in Wilson's disease, the supportive evidence could be hemolytic anemia, and if you do a retic count, it may be raised, and that picture would be helpful for you to understand hemolysis, and that will be negative. On the other hand, if the child has got chronic liver disease with established portal hypertension, there may be low platelets, and sometimes the severity of hypersplenism could cause pancytopenia as well. How are you going to interpret liver functions? We'll look at one by one. Transaminases. Generally, you do not get very high degree of transaminitis in Wilson's disease. In comparison to a 7-year-old child who has got autoimmune liver disease who might present with transaminases in hundreds or thousands, the same age child who might present with Wilson's disease will not have transaminases raised to that degree. It may be less than hundreds in 2 digits rather than 3 digits or 4 digits. So the degree of transaminitis is quite lesser compared to other differential diagnoses. Gamma GT could be variable. It hasn't got much specific diagnostic value. However, it could indicate the severity of the cholestasis. Alkaline phosphatase, quite interesting. Typically in Wilson's disease, it's said to be low. However, in most of the community people, it's confounded by vitamin D deficiency, where you get slightly higher alkaline phosphatase from the bone. So it's hard to interpret. Provided there is no vitamin D deficiency, relatively low alkaline phosphatase would be supportive for a diagnosis of Wilson's disease. The postulated mechanism is, some have stated that there is associated zinc deficiency in Wilson's disease, which is giving rise to this low alkaline phosphatase. What would happen to the bilirubin? Again, it could be variable. It might indicate the severity of the liver disease. It's important to look at liver synthetic functions, which are albumin and clotting, prothrombin time. So derangement or the low values of albumin as well as raised prothrombin time might indicate the chronicity of the illness as well as liver synthetic functions, but no specific diagnostic value as such for the Wilson's disease. And prolonged prothrombin time may just be due to vitamin K deficiency as well. So it's very important to commence on vitamin K soon after you detect prolonged prothrombin time. Ammonia again might indicate severity of phenotype if they have encephalopathy and raised ammonia. And this hyperammonemia could be acute or chronic. All the children who come with deranged liver functions, we would perform a baseline ultrasound scan. What are we going to see on the ultrasound scan? Again, features could be variable depending on the stage they present and the clinical phenotype. Increased echogenicity of the liver could be present. The reason is initial steatosis, which is seen in the pathogenesis, and fatty appearance. Presence of splenomegaly might indicate chronicity and chronic liver disease with portal hypertension. Free fluids again will indicate the severity of the disease. Any child who has got chronic liver disease, it is important to look at focal lesions of the liver because they could develop hepatocellular carcinoma and malignant nodules within the liver even in childhood. So one of the intentions of doing ultrasound scan in a child with chronic liver disease should be looking for focal lesions. So basically ultrasound scan might give some clues, but it will mainly help you to understand the stage of the disease. Now we'll move to the diagnostic investigations. Diagnostic investigations could be categorized like investigations which would look at the copper metabolism and then the genetics and liver biopsy. Three components. Firstly, we will look at the investigations which are targeted at copper metabolism. Serum ceruloplasmin. I find this is very useful test. It has a very significant sensitivity and quite specific as well, I would say. However, it has got its own confounders. The normal range is 20 to 40 milligrams per deciliter and less than 10 is highly sensitive. It's subjected to false positivity and false negativity. Ceruloplasmin is an acute phase reactant. So presence of concomitant infection might raise ceruloplasmin and give rise to false negativity of the disease. So better yield could be obtained by doing a concomitant CRP together with ceruloplasmin. And on the other hand, the conditions like aceruloplasminemia, malnutrition, and young childhood, you might have low ceruloplasmin inherently. So again, that would have some implications on interpretation of ceruloplasmin. One other important fact to note about ceruloplasmin is up to 15% of Wilson's disease heterozygotes could have low ceruloplasmin. However, it would not be significantly low, it would be mildly low. The second investigation to look at the copper metabolism is serum copper. I do not find this as a useful investigation. It has got very poor diagnostic utility. It could be low, normal, or high. So if I am left with few investigations to do, I would exclude serum copper. Though it is not much useful in diagnosis, serum copper is a useful investigation during the follow-up, which we will discuss in future slides. Thirdly, 24-hour urinary copper excretion, again a very useful test. It is important to perform the test correctly to interpret the results. There are two components in the test. One could be pre-penicillamine urinary collection, 24-hour urinary collection. The other is post-penicillamine 24-hour urinary collection. You have to make sure uninterrupted urine collection for about 24 hours to a special container, and that should be transported to the lab immediately or else kept in the refrigerator. Pre-penicillamine test is usually sufficient in most occasions, and you don't need to do post-penicillamine test in all the settings. If you decide to do post-penicillamine challenge, then you have you have got to give 500 milligrams of penicillamine at the beginning of the penicillamine challenge urine test as well as in the midway after 12 hours. If we look at the indications for 24-hour urinary copper excretion, it's helpful in the diagnosis of the index case as well as in the family screening and monitoring the response to chelation during follow-up. So what are the occasions we would select to do post-penicillamine test? It is indicated in symptomatic children where you get inconclusive results from the pre-penicillamine test. And it's not very useful in asymptomatic children. For example, if you decide to do post-penicillamine challenge in family screening who are asymptomatic, you are not going to get a good yield. I have indicated interpretation of pre-penicillamine test as well as post-penicillamine test which you could look into. The second specific investigation is genetics. It's a fascinating investigation. What we would look for is mutations in ATP7B gene. More than 700 mutations had been identified so far, complicating the matters, and the genetic testing been more exhaustive and costly. When we look at the parents in our study, there was a mixed population of homozygosity as well as compound heterozygosity. And obviously homozygosity is more common in consanguineous families. In certain occasions, pseudodominant inheritance as well as uniparental isodisomy had been reported in Wilson's disease, but that is not the typical scenario. Pseudodominant inheritance could occur when you have a lot of clustering within a certain community and consanguineous marriage. In practical setups, if you have got to do genetics test, it's very easy if you know the family mutation and if there is a person who was affected in the family earlier. If you have got a fresh index case where you've got to investigate for genetic mutations, it might come as negative depending on the extensive nature you perform your genetics. Usually the laboratories would look at the common mutations. Then they will elaborate their genetic testing further step by step, and that will depend on how much you are going to spend on the test as well. So having negative genetic test does not always mean that it's unlikely to be Wilson's disease. The other important fact to highlight in terms of genetics and Wilson's disease is there had been some ethnic variations observed in literature with certain types of mutations as well as in certain ethnic groups. For example, H1069Q mutation was commonly noted in Europe and North America, where another mutation was commonly noted in Asia. So this is one of the facts the laboratories would use when they do their genetic evaluation. One of the key messages I wanted to give in genetics is it's always good to perform genetics. However, negative genetic testing does not exclude Wilson's disease, and you could still make the diagnosis in the absence of genetics. We'll have a look at what we found in our cohort. We had 70% of the children and adolescents who demonstrated 2 mutations, and 10% had only single mutation. However, they fulfill criteria for Wilson's according to the Wilson's diagnostic score to fulfill a diagnosis of Wilson's disease. And 20% of them we could not find genetic reports, probably due to the old cohort, because we looked at the data 30 years back, and in early years we did not have the availability of genetic testing even in other countries. And if you look at the screen in the right side, you could appreciate when we categorized them into ethnic groups, we observed more compound heterozygosity in Caucasians. In contrast, there was more homozygosity in Asians. As the third important test, we would look at liver biopsy, liver histology, as well as dry copper. Liver biopsy is helpful in making a diagnosis of Wilson's disease. However, it's not confirmatory. And there are certain disorders where the histology would be diagnostic. You really need to have liver histology and liver biopsy. However, Wilson's disease is not a histological diagnosis, and liver biopsy is not essential. And what should be the role of liver biopsy in Wilson's disease then? It might give you some supportive evidence to find out the degree of liver damage, as well as it would enable doing dry copper, which is a more specific test, which is available through liver histology. So basically, by performing a liver biopsy, you might get some supportive features which would support your diagnosis of Wilson's disease, will enable you to do dry copper, and will help you to stage the disease. On your right-hand side, I have illustrated few images which indicate certain features which might be there in a biopsy of a child with Wilson's disease. The first one shows steatosis, fatty infiltration, and Mallory-Denk body is quite frequently available pathological finding, histological finding. Mallory-Denk body is cytoplasmic inclusions, and this is copper staining in rhodonine stain. And again, it's important to note, negative copper staining does not exclude Wilson's disease. For example, if your liver is cirrhotic, you might not see copper staining. On the other hand, chronic cholestatic disorders can cause copper staining in the absence of Wilson's disease. For example, sclerosing cholangitis, disorders of glycosylation might have copper staining on liver biopsy. However, it's not due to Wilson's disease. Liver copper is one important test where you could obtain through liver biopsy. It's quite specific. You need a frozen tissue and preferably more than 0.5 centimeter tissue to do proper copper analysis. The interpretation is if the value is more than 50, it is abnormal, it's not normal. And if the value is more than 250, it's highly suggestive of Wilson's disease. Values between 50 to 250 will count a score for the Wilson's diagnostic score, however, would not be very specific. And as I discussed, high liver copper may be seen in other cholestatic conditions. Lastly, out of investigations, we look at the place for imaging. Most of our investigations were targeted at the liver. Now we have got to assess the brain, and it's important to identify the disease severity in multiple organs, and it will help you to prognostify as well. So MRI images had been the traditional modality of imaging which was performed to identify changes in Wilson's disease. However, nowadays the understanding is MRI could be normal in early stages of Wilson's disease, and that might give you false reassurance. So the trend is to perform MR spectroscopy to detect early changes in Wilson's disease. And there is a predilection to affect basal ganglia as well as thalami, putamen, and caudate nucleus. So far, we have gone through clinical features and diagnostic tests for Wilson's disease. Now we will look at how are we going to make a diagnosis incorporating all these clinical features and diagnostic test. Wilson's diagnostic score is a score which was described by Ferenczi initially, then which was adopted by European Society of Pediatric Gastroenterology, Hepatology and Nutrition, and they published their position paper in 2018, which is the latest worldwide guidance available for the Wilson's disease, and they have suggested to adopt this method to diagnose Wilson's disease. This was partly to avoid delayed diagnosis and delay in implementing treatment strategies. So if you look at the score, you need to have either 4 or more to make the diagnosis. So this has incorporated clinical features like K-Frinks, and if you have K-Frinks, it has given significant importance, giving a score of 2. And neuropsychiatric symptoms or typical imaging, and then hemolytic anemia with serum copper, and urinary copper, liver copper, or else liver histology, one or the other, serum ceruloplasmin, and mutations. It's good to interpret if you have 2 mutations, then the diagnosis is made. You don't have to worry about all the other criteria. If you have got 1 mutation, still that will count for your Wilson's diagnostic score. And on the other hand, you could appreciate serum ceruloplasmin, if that is less than 0.1 grams per liter, in other words, less than 10 milligrams per deciliter, will give you a score of 2. That has been given a very good validity in the diagnostic score. So basically the diagnosis of Wilson's disease is quite straightforward, and you can use the available clinical features and diagnostic findings. However, it's always good to go and perform genetics if you have the facilities, because it will enable you to do proper and targeted family screening and to be confident in your diagnosis. Let's briefly look at diagnostic dilemmas and atypical scenarios. The differential diagnosis for Wilson's disease could be non-alcoholic fatty liver disease. In the initial stages, it might appear like fatty liver. So if you see a fatty liver on ultrasound scan, it's always good to look for Wilson's disease before you conclude on non-alcoholic fatty liver disease. And other metabolic liver diseases like OTC deficiency, urea cycle disorders will give you that typical metabolic feeling and metabolic appearance on the biopsy. Disorders of glycosylation again could be a differential diagnosis, and the commonest thing is autoimmune liver disease. In the age group you see the Wilson's disease, so it's always good to consider that as well. There had been atypical scenarios which were reported in the literature, very rare occurrences, coexistence with other metabolic diseases such as OTC deficiency. And again, in our unit, we presented a case where Wilson's disease was coexistent with triple H syndrome, and both conditions were genetically diagnosed, and where the child had a severe phenotype. And there had been literature with coexistence with autoimmune liver disease. However, it's very rare. And you should be considering this if you have very good evidence towards the second disease. Otherwise, this might delay your appropriate treatment. There are few newer tests just for you to be aware. However, they are not being validated yet, and the experiments are underway. Hopefully, they will be available in the near future to make a better understanding of copper metabolism related tests. Following the talk on clinical features, investigations, and the diagnosis, we shall move to discuss about management. Wilson's disease is quite complex, which requires multidisciplinary and specialty approach. Because child might have liver involvement, neurological involvement, psychiatric involvement, sometimes joint symptoms, so you would need multidisciplinary team to help and give the holistic and best care to the child, and might require to involve the transplant surgeons if you are going ahead with transplantation. Main modalities of treatment are either medications or liver transplantation. Management goals and the expected outcomes would differ in individual child depending on their nature of presentation, clinical stage, as well as other factors. Unfortunately, this is a disease which requires lifelong treatment, either with chelation or after liver transplant. Because even after transplant, you have to be on immunosuppressive medications for lifetime, however, with better quality of life. And when you talk about management of Wilson's disease, it is incomplete without family screening. Let's look at medications first. We all know the medications, only 3 medications which are being practiced in day-to-day clinical setup. It could be zinc, which blocks intestinal copper absorption, and the chelators, 2 chelators we have are penicillamine and trientine. So the challenge would be in which group of children you would start which. Let's look at it in this way. If you have an asymptomatic child with normal liver functions, usually the scenario is through family screening, where you detect a child through family screening, where the index case was diagnosed, and this child is asymptomatic and normal liver functions are there. So you might start zinc, anticipating the future progression of the disease because child has got the genetic diagnosis. If the child is symptomatic and having abnormal liver functions, you definitely need to start a chelator with or without zinc. If the clinical condition is quite complicated with decompensated liver disease and gradual worsening of synthetic functions, established cirrhosis, acute and chronic liver failure, acute liver failure, you've got to start chelator and zinc straight away. However, you have to consider liver transplant very early. It's very unlikely you are going to achieve good outcomes if you have established cirrhosis with chelators. That doesn't mean you will not start chelators. You will start chelators after stabilization. However, should do the transplant assessment with the golden time you have achieved after initial stabilization. And one other important fact which we should note in our clinical practice is if you get a child with suspected Wilson's disease who's having or presenting with acute liver failure with encephalopathy, you are very unlikely to rescue this liver without a liver transplant. However, I would like to emphasize it's not acute on chronic liver failure. It's not decompensated liver disease. It's purely acute liver failure where there is no indication or sign of chronicity. Purely coming with necrosis of the liver and acute liver failure with encephalopathy, you are hardly going to achieve much with chelators. So transplantation should be considered very early in this category of children. There are newer modalities of treatments like tetrathiomolybdate being trialed at the moment and not licensed to be used in children yet. The advantage is, I'm sure you must have experienced the worsening of neurological features with the use of penicillamine and up to a lesser degree with triantine. So with tetrathiomolybdate, that adverse effects or the drawback is not there and hopefully not there according to the published literature. So that is why we are hopeful that drug will be available in the near future to be used in children as well. In this slide, I have tabulated the doses, drug doses, which you can have a look, as well as reported side effects. I'm not going to go through detail, but this can be referred whenever you have a child to treat. This indicates the dosages in different age or weight categories and when to titrate, when to start and how to start. Let's look at some facts needed to be aware about chelators as well as the diet. All chelators should be given on empty stomach. And you have to know that zinc interacts with other chelators, so you should give zinc on another time where you will have a space between the chelator and the zinc. And it's a well-known fact that triantine should be kept in the refrigerator. In developed countries, they have preparations where you don't need to keep in the refrigerator. However, the preparation we have mostly is needed to be kept in the refrigerator. What about the dietary copper restriction? Is there a place in management? It's quite controversial. And it is individualized approach. If I have a child whose liver has got cirrhosis, significant cirrhosis, and who would need liver transplant in the near future, and I'm hardly going to achieve much with chelation, I would not be fussed about restricting dietary copper. However, if you have an early presentation where you are likely to achieve good outcomes with chelators, yes, I would be happy to go through this dietary copper restriction, at least where I would achieve some stabilization in the liver function tests. Looking at the adverse effects, zinc is quite safe. It's well known to cause GI side effects, sometimes requiring withdrawal of the drug as well. However, it's quite safe. Very rarely it might cause neutropenia. Side effect profile of penicillamine is well known. It could cause skin reactions, proteinuria, and lupus kind of a syndrome where you have to monitor these children for these important side effects. And sometimes significant cytopenia, so nephrotic range proteinuria might require withdrawal of the drug. And after a period of time, you might introduce it with the low dose, provided the severity was not enough for you to consider it. And how are you going to overcome this neurological worsening, which could happen with these chelators? It depends on the severity of the neurological features you would get with the use of chelators. If it is mild to moderate, you might reduce the drug dose and continue. And if it is very severe, you might stop the drug for a moment, maybe for a short period, then restart and see from a lower dose. However, they need to be on chelators, so you have to have a solution for that. If you are desperate that you cannot use chelators, then you have to move to liver transplantation as the next option. Triantine again could cause GI side effects, arthralgia and sideroblastic anemia. However, the side effect profile is quite lesser compared to penicillamine. Mostly in most of the protocols, triantine is used as the second line. However, especially in United States where they have enough economical support to use triantine as the first line, families do request to use triantine due to the lesser adverse effect profile. So there is no hard and fast rule like you have to use penicillamine first. If the family or if the country could afford and if it is cost effective, you could still use triantine as the first line. However, you have to consider the efficacy and well-known data about the efficacy as well as the side effect profile. What I would personally prefer is to start with penicillamine because the effect of chelation is well known, efficacy is well known compared to triantine, and if I see side effects, I might shift it to triantine. Now we have reached to the follow-up. How are you going to follow up a child who is on chelation? What, how, and when? You need to follow up disease activity, drug adverse effects, as well as other organ involvement like neurology, eyes, and others. And how can it be done? It could be done clinically as well as investigations and other assessments as I have indicated here. And the frequency of follow-up, initially you have to follow them up very closely soon after the diagnosis. And once they have been stabilized, maybe monthly, then 3 to 6 monthly. And it is always important to check the adherence to the medication during the follow-up, and that should be the first differential diagnosis if you see a flare-up of liver function tests. And if you have made a change in the drug or dose, then you have to do more frequent follow-up. And these children also deserve other aspects of care as per chronic liver disease if they have got chronic liver disease, such as optimization of nutrition, surveillance endoscopies, and relevant medications as well as optimum management of their acute episodes. The second part of that management is liver transplant for Wilson's disease. Liver transplant is the other recognized modality of treatment in addition to chelation. What would be the indications for liver transplant? Acute liver failure with encephalopathy, not responding to chelation. As I have mentioned earlier, it's very rare this group of children would respond to chelation. However, it could happen. You can start chelation and see while you are assessing for the liver transplant. Acute and chronic liver disease with established cirrhosis, again, you have to go through with the transplant assessment. Worsening liver synthetic functions or progressive portal hypertension in chronic liver disease. And if the child has developed complications related to chronic liver disease, such as hepatopulmonary syndrome. One might ask, is living-related donation is possible, being the parents are heterozygotes? Yes, it is possible, and heterozygotes will not have the disease, so they can be a donor for live donation, and the outcomes are similar to a non-related donor. In this slide, I would like to emphasize the importance of transplant assessment and what do I mean by transplant assessment. And it's good to understand transplant assessment is not equal to liver transplant. Transplant assessment is a process where you go through with the child and family in terms of assessing the child for few things, like candidacy of the transplant, whether this child is a suitable candidate for liver transplant. Are there any contraindications in this child for liver transplant? And what should be the best timing for the liver transplant? If the liver transplant is indicated, is it now or later, or can you wait? And to identify the best type of donor. And during that process, you will counsel the family and explore the socio-economic factors with the help of the multidisciplinary team. So it's kind of a process where you go through with multiple specialties and together with the family to understand the logistics as well as the candidacy for transplant. So going through a transplant assessment does not mean child is going to have a liver transplant on the next day. It's a process you would do to understand these facts I have already mentioned. This is King's-Wilson index, where King's group have come across with all these, where King's group developed these parameters to prognostify acute liver presentations and the mortality without liver transplant. The recommendation was, if the child has got 11 points or above, we are unlikely to salvage this liver without liver transplant. So it will be helpful in the process of listing for liver transplantation. How would the neurological features affect liver transplant? Liver transplant is not indicated solely for primary severe neurological phenotype. If you have a child presenting with severe neurological features and does not have much liver involvement, you are not going to offer liver transplant as the curative mode. On the other hand, presence of mild to moderate neurological features will not preclude child going through transplant as well. So these neurological features should be interpreted in an individualized manner in the given context. At the same time, if I am to tell briefly about post-transplant care, it would be standard liver transplant care. And child should not need any chelation afterwards and need monitoring for neuropsychiatric features, because the damage which has already occurred to the brain might cause some psychiatric or subtle neurological features to manifest with aging. Last but not least in the management, family screening. It's quite easy to understand. Who do you screen? You have to screen first degree relatives. How do you screen? If you know the mutation in the index case, it's easy and straightforward. You will do targeted genetics. If not, you have to start from the basic investigations and proceed just like an index case. How do you treat? It's important. Usually these children are asymptomatic because they are detected through family screening. However, if they have deranged liver functions, they should be treated similarly to an index case. Asymptomatic and young children who are identified through family screening, if they are less than 3 years and liver functions normal, if they are more than 3 years, you have to start zinc and chelators irrespective of the liver functions. If they are more than 3 years, though their liver functions are normal, you will start zinc or chelators. If the liver functions are normal, I might start with zinc and later on might add a chelator depending on the need, if the liver functions are normal. If they are less than 3 years, I would not start zinc or chelators just because they have a genetic diagnosis. However, I would monitor them very closely. And whenever the time comes where their liver functions or transaminases become abnormal, then I would introduce zinc, and later on, depending on the response, I might add chelators. And no treatment is required for heterozygotes. And it's very important to do genetic counseling when you are handling these families. At the end, we would look at the outcomes of children after proper management of Wilson's disease. The outcomes are generally good in both chelation and transplant groups, provided the treatment modalities are appropriately chosen. And I would like to say outcomes rather than prognosis, because prognosis is something which would inherently occur with the disease. On the other hand, outcome is something that you would try to achieve by using your knowledge and available treatment modalities. And good quality of life and survival had been reported. And there are several factors which might affect the outcome of the Wilson's disease. And you could see these two adolescents, the one on the top won so many gold medals in transplant games following his transplant after a few years. And the second young lady who completed a degree in nursing a few years later following the liver transplant. What are the future directions? Nowadays, people are talking about multidisciplinary approach and expert Wilson's clinics where they would incorporate liver specialists as well as neurologists, psychologists, and all the other physiotherapists, occupational therapists, family support workers, specialist nurses to conduct specialized or expert Wilson's clinics. And we would expect better diagnostics in the future as well. Newer drugs are being trialed and we are waiting for tetrathiomolybdate. And gene therapy, human hepatocyte transplantation again being assessed and evaluated for Wilson's disease. This brings me to the end of my presentation, and in summary, I would like to say Wilson's disease is rare as per available epidemiological data. However, it is not rare in clinical practice. It's quite heterogeneous disease with diverse presenting patterns. Neurological features are often overlooked in children and young adolescents. You need to have high index of suspicion to make the diagnosis, and it could be aided with Wilson's diagnostic score or genetic testing. Appropriate and timely treatment results in good outcomes in short term as well as in long term. Lastly, I would like to invite you to read through this review, which I published together with the co-workers in Birmingham. This was published in Archives very recently. It gives a detailed account on Wilson's disease in children and adolescents. And thank you very much.